I think we all need to be familiar with this drug. And at the same time, we need to be respectful of it and cautious of it, because with familiarity, we can get a little complacent.
Wow, that is a huge subcutaneous dose. Oh my goodness.
Yeah, we come a long way with our shots, I'll tell you.
That's for sure.
I'm an infusion nurse, so I can see things through a tunnel vision, but you could be a nurse who's answering a phone call from a patient, either an office nurse or triage nurse, and the patient says, I got my Rituxan 2 weeks ago, and I've got this terrible rash that's developing. And we may not put two and two together.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Seth Eisenberg, Professional Practice Coordinator of Infusion Services at Seattle Cancer Care Alliance in Washington, and member of the Puget Sound ONS Chapter, to discuss how to safely administer rituximab. This episode is part of an ongoing series about chemotherapy administration. The others are linked in the episode notes. Thanks for joining me today, Seth.
Oh, thanks for having me on. It's my pleasure.
So to start us off, rituximab was the first immunotherapy used in cancer care when the U.S. Food and Drug Administration approved it 25 years ago for diffuse large B-cell lymphoma. Today, can you tell us what diseases, cancer and non-cancer, is rituximab used to treat?
Sure. In oncology, it's still used for various types of lymphoma. That would be like non-Hodgkin's and follicular lymphomas. It's also used less commonly, but it's used for chronic lymphocytic leukemia. And then there's a list of autoimmune diseases that it's approved for, such as rheumatoid arthritis, granulomatosis, NPG, and lupus. There's also some indication for MS, for multiple sclerosis, and some off-label things as well.
Okay. Since it is an immunotherapy and we do look at chemotherapies and immunotherapies similar and sometimes different, how is rituximab administered and how does it work to stop the growth of cancer cells?
So there are two routes now for rituximab. The original route was intravenous and the newer route is subcutaneous. It should be mentioned that anyone who is going to get the subcutaneous needs to successfully complete an IV dose first. That has to do with the reactions, which we'll talk about here in a bit, I'm assuming. So IV and a sub-Q, the IV is titrated on the first dose for administration.
How does it work to stop the growth of cancer cells?
Monoclonal antibodies generally have the ability to find a CD, a cluster of differentiation, which is an antigen coating on many, but not all, cells in the body. And this happens to be an antibody that targets CD20, which coats B cells. And it's very specific for that. That's the whole premise of monoclonals versus chemotherapy. Is pretty general, where it looks at those rapidly dividing cells, whereas monoclonal antibodies have the ability to target specific cells with this coating on it. And the problem is that, in general, simply finding the target isn't good enough. There's certain things they build into these antibodies which enable them to then recruit immune cells, such as natural killer cells and other types of T cells, to that target B cell, and that in effect helps destroy the B cell.
Gotcha. So you mentioned a minute ago with the administration of rituximab that we do titrate the dose, especially the first time for patients because of common adverse reactions or side effects. Can you talk about what some of those are?
Sure. So I'm going to talk about the side effects, but I also at the same time want to talk about how the drug works, because the side effects are tied to how the drug works. So during an infusion, and typically most of the infusion-related side effects occur with the first dose. In fact, it's about 80% of the reactions occur with dose number 1, and it decreases dramatically to dose number 2 and dose number 3. Statistically, it goes down to like less than 5% usually by dose number 3. What we'll see on our first dose, for example, is fever and chills and shortness of breath, get up hypotension, nausea, vomiting, diarrhea, hives. And this has to do with the fact that the drug works 2 ways. So I talked a minute ago about the recruitment of those immune cells. We have 2 mechanisms here. One is the antibody-dependent cellular cytotoxicity. This is where the variable region of the monoclonal attaches to the B cell, and the fixed region of the antibody then attracts these cells. And what happens is that you get immune cells that release all these cytokines. And we're talking about interferon, and all of those are responsible for these side effects. So for an example, just got IL-2 will cause anxiety or pain. You can get fever and chills, and you can get dyspnea and tachypnea. The other way that this drug works in particular is through something called CDC, which, not to be confused with the organization CDC. This is complement-dependent cytotoxicity. And so the complement system, which we could probably spend 30 minutes just talking about complement, but I won't go there. But the complement is sort of the first offenders in the body. And the complement is a cascade of events that has to occur in sequence. I think most nurses are really familiar with the clotting cascade. Complement is similar in the fact that you have to reach a threshold for each one of these to trigger the next in part of this complement. Once it's triggered, it tends to target mast cells. And the mast cells have granules in them. Now, mast cells are interesting all by themselves because unlike any other immune cells, they don't circulate, which makes them weird. But they're in fixed locations. And so you can find them in the skin and the lungs, the GI tract, and the blood vessels. Now, if we think about where those mast cells are, it really explains the symptoms we will see with them, because the mast cells have histamine in them, and they also have heparin, but the histamine is the big player here. So when complement tells the mast cells to release this histamine, the histamine then causes things like flushing and rash and nausea and vomiting and other types of side effects that we see with histamine release and bronchospasm. So you can see that the side effects that we have during an infusion reaction are actually quite related to how the drug actually works to target those B cells.
It's a complicated process.
Very much so. It is. And we think about chemotherapy just going after those rapidly dividing cells, but it is much more complex, I think, for these antibodies.
Right. I like that analogy because you're right. The chemotherapy is just pretty, I'm going to say basic. That's probably not the best word to use for it.
Broad, general.
Yep. And can, like you said, goes after the fastest dividing cells. But with the immunotherapy and looking at finding ways to use our own immune system to help battle this and just the complexity of it. So talking about that complexity, what might be some misconceptions about rituximab that are out there commonly, especially when we were just talking about those adverse reactions? What might be a misconception that somebody would have about how they happen, or just something else?
Sure. So first, we should make mention that the reason why this seems to happen on the first dose more than other doses is because the patient has more B cells at that point. The ability to clear B cells is pretty dramatic with this drug, and you can reduce it by over 90% just with one dose. So when they get their second dose, the reason why they don't react as much is because there are fewer B cells to be reacting with in terms of the amount of recruitment of immune cells. So I think, but more to your point, one of the confusing things about this is that a lot of people tend to think that the reactions to Rituxan have to do with the fact that it is a murine-based, rodent-based antibody. And I think just a really brief discussion on this will clear this up a little bit. So there are 4 ways that these monoclonal antibodies can be grown, and essentially they're assembled or grown. The first type of antibody which was fully murine, and this, like the example of the one drug that's still on the market, is tocilizumab. And I need to, if I can digress, I need to give people a real helpful hint, because you can look at the name of any antibody and tell how it's made, and this gives you some indication. So if you look at the middle syllable, and if you look at tocilizumab, it's got the MO in it. MO means mouse, which is easy to remember for MOUSE. So tocilizumab. Rituximab has an XI in the middle. Rituximab, like cetuximab, rituximab, and that means chimeric. And chimeric means it's a blending or a mixture And that's an easy way to remember it. If you remember, mixture has an X in it. So if it's got an X in it, it is a mixture. And chimeric is only about 25 to 30% murine. Now, the reason why they went from fully murine to a chimeric is not because of reactions. It's because of something called HAMA, H-A-M-A, HAMA, human anti-murine antibodies. And what this is, it's discovered with the first monoclonal antibody, which is called OKT3, was a commercial failure, only because, or largely because, when you gave a first dose, the patient developed antibodies to the mouse protein. And then when you gave a subsequent dose, the entire antibody was cleared out of the system before the drug had a chance to do any work. So those antibodies moved it out. So it was right after the researchers said, we need to try to find a way to get rid of some of this mouse protein so that the body doesn't clear it out through the reticuloendothelial system. So that's why we have a chimeric. And there are a lot of ones out there that have an IX, or an XI rather, in the middle. The third type is humanized, and this has about 15% rodent in it. And that has a ZU in the middle syllable, such as bevacizumab. So if you look at that ZU, 15%. And then newer antibodies, a lot of them are fully human, which basically they've taken out all the DNA that was originally in the original rodent, and it's fully human, and those have an MU in it, like daratumumab. Now, if you've ever given daratumumab, you will know that there's a reaction rate that's even worse than Rituxan. It's 40% of the patients who get a first dose dara will have a reaction. So if it's fully human, why are they reacting? It has nothing to do with the mouse. It has completely to do with how the drug interacts with the target cells and how it recruits those immune effector cells. So I think that's just an interesting thing to keep in mind of what's causing it. And this is the way to explain it to patients as well. For patient education, you can say that reactions are common with rituximab, but it's because of how the drug works. It's not because that this is an unanticipated side effect. We anticipate it, and we're going to give you pre-medication, or we're going to give you acetaminophen to help prevent fever. So we're going to give you diphenhydramine or Benadryl for histamine. We may give you another histamine to block it in your GI tract. And we may even give you a steroid, it's a Dex or methylprednisolone, depending upon the regimen that you're getting, again, to try to lessen the side effects. But these drugs that we're giving for pre-meds don't necessarily prevent the drug from working. They don't prevent those immune effector cells, but they prevent some of the receptors. So we're not actually having as bad of a reaction to it. But even with pre-meds, patients still react.
That was a really good explanation. And I think that's something that probably isn't talked about that often with rituximab. And I think that it's something that I appreciate the way that you explained it, because I think more people need to know and understand that piece of it, exactly what you were saying about how it affects our immune cells and our immune system to activate it. And those are some of those reactions that we're having, and not the reaction to the medication. And I think that's a really good example and way to understand it more.
Yeah, and from a patient's perspective, they're just trying to get through the treatment. So we have to judge how much information to give them, of course, to not overload them with things on this. Because with Rituxan, there are other things that can be a side effect aside from the infusion reactions, in such like tumor lysis syndrome, for example. And this is particularly a problem with patients that have a really high number of B cells circulating, such as greater than like 25,000 is the cutoff. I think we as nurses and physicians have done a fantastic job lately in the past decade or two in preventing tumor lysis. We just don't see it as much as we did years ago, which is great. That's great news. But we have to remember that it can always be a problem. Infections are a problem because you're basically attacking the patient's B cells. And there are other less common reactions, such as skin reactions like Stevens-Johnson syndrome, and hepatitis B reactivation can happen. And I should mention that patients with Hep B can still get treated, but it's recommended that they be followed by a hepatic specialist, because patients can die from their hepatitis reactivation. Because again, we're knocking out those B cells, and the B cells have such an important role in immune surveillance for that. Probably the last thing to mention, because it's rare, but it's also 100% fatal, and that is PML, which sounds like a type of leukemia, but that's progressive multifocal leukoencephalopathy, and this is caused by the JC or John Cunningham virus. And it's something that is worth mentioning, regardless of whether this is an oncology patient or not, because if a patient develops any kind of neurologic changes that are not associated with anything that else the patient has, any other comorbidities, then the team needs to know this. They need to understand what's going on, because if it is JC virus, they're going to stop treatment on this, because it's definitely a fatal thing.
Yeah, thank you. Those are all great things to know and to understand. And I think, as you said, as oncology nurses, we need to be thoughtful about what education we are giving patients. Not that we hold back on any education, but how much they can absorb. But the important part, or more important part, is that we, as the oncology nurse or nurses in a non-oncology setting who might be giving these medications, understand what and how these medications work, because we have to know if we're seeing any of those reactions or side effects, why is it happening, and what we can do to help waylay those responses to our immune system, and to knowing that this is a potential to happen with this treatment.
Oh, absolutely. I'm an infusion nurse, so I can see things through a tunnel vision, but you could be a nurse who's answering a phone call from a patient, either an office nurse or triage nurse, and the patient says, I got my Rituxan 2 weeks ago, and I've got this terrible rash that's developing. And we may not put two and two together and think that this is a possible reaction from the drug. We may think it's something else. Yeah, it's always important to even if we don't educate about every possible thing that can happen, we as clinicians need to understand this so we can help put the pieces together.
Absolutely. So, are there any patient populations that should avoid this treatment? You mentioned the patient with hepatitis or a history of that, but are there any populations that really should avoid it?
There's always the risk-benefit thing when with all these therapies. Certainly, there are people who the drug manufacturers will tell you, if you have any kind of an allergic reaction, a serious allergic reaction to a drug, you should not get it again. It's unusual for patients to have a true allergy-mediated reaction to rituximab, but it is certainly possible. Again, the patients who have severe cardiac problems or cardiopulmonary problems are at higher risk of having cardiopulmonary or failure from receiving this drug. But that becomes a discussion with risk-benefit between the team and the patient itself. And I'm not actually aware of any specific other limitations for patients outside of the obvious ones.
Okay. And I just want to circle back one more time on the education. So you talked a lot about the things that we would talk to the patients about side effect wise and how we administer. But is there anything else that you can think of specific that we should take care of for patient and caregiver when these patients are receiving rituximab? And it could be, like you were saying, something that you make sure you tell them to call in for later on. And it may not be immediate and acute kind of things, but is there anything else that we didn't touch on for that?
Well, of course, since we're affecting the patient's immune system, we want to make sure we talk to them about calling us if they got any fevers, chills at home, because neutropenia. So Rituxan is not always given by itself. It's usually given in combination with other chemotherapy, and neutropenia can occur with or without chemotherapy. So we want to make sure the patients are aware of the fact that their immune system is going to be impaired and that they need to avoid anyone who's sick intentionally. They know someone who's sick. They want to make sure they call in if they have any kind of fever or chills, any kind of symptoms at home for that. So they are more susceptible, more vulnerable. We already covered some of the skin-related problems like that. And then regarding the subcutaneous version of the drug, rituximab, I think there's a lot of education that's just evolving with that drug itself, because if you tell somebody you're going to get a subcutaneous injection, you think, oh, it's a quick little shot and I'm gone. But one of the groundbreaking things about the rituximab was that its volume is huge. It's either 11.7 or 13.4 milliliters. Now, that's unheard of. 5 years ago, we would never give somebody a shot that big, and patients would have no clue that they were getting something this big. So what I've done with my patients is I tell them that this drug is very special, that it's built with something called hyaluronidase, which helps the drug get absorbed quicker into the system. Because when I first learned that this drug was such a high volume, my visual impression was that these patients were going to have a ping pong ball sized lump in their abdomen after giving this drug, or that when I pulled the needle out, it was going to squirt out like a geyser. It's like, because if you look at what the reference books generally say, 2 to 3 mils at the most for sub-Q injections. And historically that was true, but that was in a different era of subcutaneous drugs. So you got a large volume. It also means that it takes a long time to give this drug. It's 5 to 7 minutes. Now, nurses are not used to giving shots over 5 to 7 minutes. It's just not something that people were taught to do. You want to make sure that as a nurse that you are in a comfortable position. And I tell the patient, this shot's going to take me 5 minutes to give you. So I'm going to get comfortable. I'm going to sit really close to you and we're going to get in a position where I can do this so that I'm protecting my ergonomics, of course, but that's also that I'm not going to be unintentionally moving the needle around in this patient's abdomen because I'm not in a comfortable position. And the patient needs to know up front that this is not just a quick in and out shot, that this needle is going to be there. The good news is that there is no correlation between the length of injection and the amount of discomfort. And this is an interesting thing that came out of some studies that it just doesn't happen because these drugs are fairly viscous. In fact, the Rituximab product subcutaneously is 12 times thicker than the IV preparation. So you imagine pushing that through a syringe, it's going to take you longer. It actually causes less pain than some of the quick little shots, like growth factor shots that tend to hurt a lot, but there's very little volume. So I always tell the patient, hey, this is going to take a while. We're going to sit and we'll chat. And I just talk about all kinds of topics to distract them, but to let them know about that. And so that's part of the patient education. And with that, there's always a possibility of a reaction with the subcutaneous, but since it's on a second dose or subsequently later doses, the chance of a reaction goes way down with it. We still tell the patients what to watch for, but it's 10% or less that they're going to have a reaction. And it's generally milder than it would be with the first dose IV. So that's all part of the patient education as well.
Wow, that is a huge subcutaneous dose or volume. Oh my goodness.
Yeah, we come a long way with our shots, I'll tell you.
That's for sure. And I would have had the exact same thought when they told me that was the volume, as you said, seeing this ping pong ball or coming right back at you.
Yeah,
wow.
Yeah, because this is not what we were taught to do in school.
No, not at all. Okay, so we mentioned how it is given in some non-oncology diagnoses. Are you seeing that it is being administered by oncology nurses going to off the oncology floors to administer this, or is it being administered by our nurse colleagues that are not trained or don't work in oncology? What have you seen?
I've seen both. And it's a mixture of good news, bad news, because the good news is if I've got RA, rheumatoid arthritis, I don't want to be going to an oncology nurse. I don't have cancer. And a lot of these things can be given in infusion centers, and not all infusion centers are oncology infusion centers. Some of them are just general infusion centers where people come for all kinds of infusions. So you're seeing a mixture of nurses, some of which are oncology, if it's done in oncology settings, but there are a lot of patients being seen in non-oncology settings. And the challenge here is that not all of the non-oncology nurses are getting the education. I've had the pleasure of speaking to a lot of the members of INS and INS members. Some of them are ONS members as well, but a lot of them are infusion nurses, but they're not oncology nurses. And some of these nuances, and certainly what we've talked about today is more than just nuance, but a lot of this information doesn't trickle down to the non-oncology nurse, especially for a drug that starts off as an oncology-specific indication and is now being given for other things. It's like, how do these nurses get that information? And so that's why I always jump at the chance to be able to help educate non-oncology nurses about this drug or other drugs. Methotrexate's another example of a drug that's used outside of oncology. And a lot of the nurses who are giving that drug don't know it's hazardous. They don't know anything about it. It's just a drug.
As you go out and have the opportunity to talk to some of those non-oncology nurses who are administering, are there any clinical pearls that you share with them or specific training and education that they need to administer?
I think they need the exact same training that we as oncology nurses need, because although like patients with RA, there's a lower reaction rate for these patients because they don't have as many B cells doing things, so they don't react as much. They still need to know the same things because the same side effects can occur regardless of disease. It's just the percentages change, which is why they always test these drugs with different populations of groups before they get approval, because they want to make sure what the side effect profile is. So they need to know the same things. They need to know how to give the drug, what to look for, and the same patient education as well.
Okay, great. That's good to know. And I think that for our listeners today, we probably are going to have new oncology nurses as well as non-oncology nurses. And I think, and probably some educators and some experienced oncology nurses. And it's a good idea and for them to realize that the importance of knowing everything that you can about the drug, how it works, the side effects, the adverse reactions, how to handle it. It just doesn't change based off of whether they're in oncology or not.
Exactly.
We talked a little bit about, you mentioned hazardous agents. So the National Institute for Occupational Safety and Health, NIOSH, dropped rituximab as a hazardous agent. There were some threads on the ONS communities where ONS members still consider it high-risk drug that requires double check.
Right.
Why is it not currently considered hazardous? And what are some best practices for people who are administering the drug, both in oncology and non-oncology settings? However, I want to preface or say, even though I said that, you just mentioned it really shouldn't matter as far as where the drug is being given. I think that's important. That's an important point for people to remember, that where the drug is being administered should not change what we're talking about and what I just asked you about as far as considering it hazardous or not.
Exactly. And I would like to separate double checks from being hazardous, because there are other drugs used even outside of oncology that get double checked. They're not hazardous. They're just dangerous. And I think that's the double check here is more to do with the fact that these drugs can be seriously dangerous for patients, especially at the wrong dose. So separating that out. But more to your point about hazardous. So if you look at the definitions that NIOSH uses for a hazardous drug, which actually came from ASHP, the pharmacy organization, it meets the definition of it, which is why it was there to begin with. The problem with the monoclonals, and this is an interesting topic, is that while the drug may be hazardous by definition, monoclonals are large molecules, and drugs like cyclophosphamide or doxorubicin or paclitaxel, those are small molecule drugs. And when we talk about small molecules, we're talking about the molecular weight. So for an example, if you take a drug like cyclophosphamide, which is probably one of the most hazardous of the hazardous drugs, it's got a molecular weight of about 300 to 400 Daltons. There's some evidence out there that drugs that are under about 500 Daltons, plus or minus, aren't readily absorbed through the skin. And it's a little squishy number, but okay, it's 500, let's say 750, we'll go up another 50%, 750 Daltons. If you look at rituximab, it's about 140,000 Daltons in its molecular weight. So it is an enormous protein molecule. And we all remember from school that the protein molecules are big, and that's why you can't excrete them through your kidneys, because they don't get through the glomeruli. So they're huge molecules. The problem is these drugs can't be absorbed through the skin. And dermatologic absorption is the number one mode of absorption when we're talking about risk for being exposed to hazardous drugs. Now, I suppose if you were inhaling or drinking it, you could probably get it that way. But that's why we wear PPE. PPE is to protect our skin from exposure. And there's zero evidence to support that these monoclonals can get in through the skin. They're just not absorbed. They're too large to get in. So that was the reason why NIOSH had taken them off. And it has created a ton of confusion, because on one hand, it is hazardous, but on the other hand, it's not on the list, or anybody's list, really, the NIOSH lists.
Gotcha. Thank you for that. That little lesson there and reminder of why those drugs are on that list. And it's a good thing to think about. And I also appreciated how you talked about separating the double check from that hazardous agent, because you're right. There are a lot of non-oncology drugs that are, as you put, dangerous, that we really do need to have that double check. And that's why. So another community thread, an ONS member asked about how to treat a rituximab spill. Are there safe handling recommendations for rituximab in regards to a spill?
Generally, there's not much different about it. It is essentially a biologic product. You could handle it as a biologic. There's not a lot of data because it's not absorbed through the skin. We don't have the same exact concerns we have if we spilled a chemotherapy agent. So that's the first thing, is to get out of the way there on that. And depending on the organization's policy as far as where this gets put, as far as the waste products used for cleaning it up, there's actually no data that says that you need to use bleach or you don't use bleach. It's not a live biologic product, so it's not like you've actually dumped a bag of platelets onto the floor where you've got a live cellular product there, which is a whole different issue. But it's actually, it's a biologic product in that it is not hazardous like the chemotherapy is hazardous. And we don't have any data to say what's the risk of inhalation on this at all. It's very difficult to study these kinds of things in terms of aerosols anyways. And it doesn't vaporize, so this is not a vapor-related issue, in which case we need a PAPR or some kind of other cartridge to help us out.
Okay, thank you. I think those are all good points to know. So we're coming to the end of our time, and we have talked about a lot of different things with rituximab and a lot of important information. So for those who are listening and may want to get some more information or learn a little bit more, what are some resources for both patients and providers to learn more about rituximab?
For a provider's point of view, if you want really good nursing-specific things, I always send people to the ONS books. And that's not just a plug. I just think they're written for nurses. So I think that's a good place to go. The manufacturers, this is something that's great. Prior to about 2000, there really wasn't much of anything on the internet. And so it was really hard for nurses to get information. I think now the companies who make the drugs have just done an incredible job of putting information on their websites. And I think that is an excellent place to go because this is information vetted by the company. They back it up with their studies. They've been vetted by their lawyers. So I think there's great information that the companies put out. Certainly the companies also have experts in terms of educators that can also provide additional information. So I tend to like that because it's like going right to the source rather than a third party who's taking up a little bit of this, a little bit of that, and sticking it on somebody else's website. So I think that's a good source for that. And then we as nurses have to distill that information down into what's relevant for patients. I know there's a lot of discussion about what's the best patient education materials, and there's about 50,000 opinions on that we don't have time for. But those are my recommendations personally.
Okay, thanks. As I said, we've gone over a ton of different things, and thank you so much. It was all excellent information. So do you have any final comments for us today?
No, again, thank you so much for having me on to do this. This is one of not the oldest, but it's certainly the oldest monoclonal that we're using out there, and it's being used for more and more things. I think we all need to be familiar with this drug. And at the same time, we need to be respectful of it and cautious of it because with familiarity, we can get a little complacent. And I think we just need to keep that in mind and just remember that those infusion reaction things are anticipated and we should be just really skilled in how we deal with them and that every institution should have a policy procedure on how to deal with the reactions.
Great. Thank you so much, Seth, for joining me today and for all of your knowledge and information on this.
You are absolutely welcome. Thank you for having me.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.